Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a huge honor for me to introduce our guest, Dr. Alfonso Pineyro. Alfonso, thanks for being on the show with me today.
Thank you.
It's a great honor to have you on. I know I heard you lecture at a Seattle Study Club event that I was at, and I thought, this guy really knows his stuff about dental implants and how to restore dental implants. And I thought maybe you could condense down your 4-hour lecture to about 45 minutes for me today and just get some golden nuggets for our listeners. So
sure.
First thing I want to do is ask you a couple of questions, just in case some people haven't heard of you. You're a prosthodontist, and why don't you tell people where you graduated dental school, your AEGD program, your prosthodontics, and then kind of fill us up to speed with what you're doing now with your practicing and lecturing.
I did my dental school at the Universidad Autónoma de Guadalajara in Mexico. And then after that, I got accepted to a 2-year AGD program at the University of Rochester Eastman Dental Center, and that gave me my U.S. degree. And then I did a 3-year residency at the same Eastman Dental Center. And then from there, I moved out to Seattle, Washington, and I've been practicing in the Seattle, Washington area since 2007, so 10 years, believe it or not. And I started teaching at the University of Washington part-time when I first moved out here because I didn't know anybody in dentistry in Seattle, coming from the East Coast. And after that, I got involved with a group of doing research and lecturing. And I'm practicing now in downtown Seattle in a practice, in a pros practice.
Well, I'd say that's plenty to hang your hat on. I mean, I just did 4 years of dental school, and that was more than enough. But I'm always impressed when people do further AEGD and prosthodontic or oral surgery or periodontist, because it's not just 3 years of more school. It's 3 years of really getting down and dirty with the details and the minutia and mastering kind of high end stuff. So I always think that's really impressive. So how much of your time do you spend practicing, and how much do you spend lecturing and research?
I do 3 to 4 days of private practice, and then I lecture maybe 3 to 4 times a month. Usually I try to keep it on a Friday. So sometimes I have to travel on a Thursday, depending where I'm going to the East Coast. It's hard to get there in 2 hours. So I have to leave half day or early morning Thursday, depending. And research, I've been sort of taking a break at this point because I have 2 young kids that need my attention. So I do a little bit here and there, but not as much as I was doing in the past.
I can understand that. I've got a couple little ones at home, and I know you want to be home with that, and they steal the show when you're home, so not much else gets done when you're there. So, I wanted to dive into, I've got like 1,000 questions I want to ask you, and I know I don't have that much time. So one of the first things I wanted to address is kind of something that you talk about in your lectures is, what do you think the most common problems are with people either placing or restoring implants in private practice these days?
I think that the main problem is, I like to say it's a lack of respect. What I mean by that is, we're dealing with, highly researched medical devices. These are very sophisticated medical devices. And I think that, unfortunately, in dentistry, we don't give it the respect that it deserves. And I say that goes across the board. You can drive down in California and see a billboard that says dental implants $395. And I think that cheapens what we're able to give our patients. And I think patients get the wrong perception of dental implants because of that. So I think that, and I would hope that as a profession, we could change our attitude towards implants and give them the respect they deserve. Because if we do that, then the patients will perceive that respect, and they'll understand why they're expensive and why they're time consuming, and, what we do to make the best result, why it takes an extra appointment here and there. They would appreciate that, but, they're being driven. Oh, you can do this in one day, tooth in a day. And then they come and they say, well, why can't we do this in one day? I don't know if you've ever heard that in your practice, but, they come to me and I say, well, these are the number of appointments we're going to need. And they say, well, I heard that this can all be done in one day. And, depending on what we're doing, that's not always true. So I think that's the big problem right now. And it's more geared towards patient perception. I wish we could change that as a profession. I wish we could give the patients, something to respect.
Yeah, I get that asked all the time. Well, how come we can't just do this in a day? And I say, well, we can, but I can't guarantee it's going to work. And when it falls out next month, I'm not taking the overnight phone call. So
exactly.
No, I think
exactly.
I think you're right. Patients and doctors both, respect the process.
Yeah.
There is a due process, and you have to respect that or deal with the consequences. So. Right.
And, the marketing just kind of pressures us as well, because like you said, we can do it in one day. And, I've unfortunately sometimes buckled under the pressure and paid the consequences, so I try not to do that anymore. But, young dental students coming out, somebody comes into their office and says, well, can you do this in a day? And they say, well, yeah, I've seen a lecture where they can do this in a day, so maybe we can do it in a day. But it's all about case selection. I think that's, the other big problem is understanding your case selection. And that's something that's not taught at dental school, unfortunately.
Yeah, it's knowing when to say no can be the most important thing you can decide in your day. Now, what are some of the going into specifics? I know I've heard you lecturing about a lot of things. I guess so. So just to cover some of the basics, what are the recommended torque settings when it comes to implants for placing temporaries and final abutments? Where are those set these days, and where are those limits kind of derived from?
I have no idea. I think that's dependent on many factors. I don't think there's a strict rule of thumb. Are you talking about immediate temporaries? Are you talking about heel temporaries? So there's a huge range of different protocols that I kind of follow in my practice.
Do you think you can dive in there and just go through maybe 5 or 6 settings if someone was just getting in implants and they think, okay, I thought somewhere I heard 35 and somewhere I heard 70 and I don't know what those mean, or what different scenarios would implicate different torque settings, and why might that be beneficial to know at least a little bit of the basics about that?
Well, torque, the torque setting is derived from the manufacturer, and depending on the manufacturer, some implant companies are 20 as their final torque. Some are 35, some are 30. And I think we have to respect what the manufacturer has given us as the torque setting because they've studied that. They've done tests on that. And that's where they derive the torque settings from. And the torque settings come from achieving the preload. And once the preload is achieved, that's where you want to be. So I think that's something that you really have to look at is what the manufacturer is recommending. And I also think that when you're in my practice, my protocol, you said about temporaries. If I'm doing a temporary single crown and the implant's healed, then I'll look at what the manufacturer says for their temporary screw. Because sometimes the screws are slightly different or the connection's slightly different because the screw is screwing into plastic and not a hard material. So you have to also respect that. If it's a single tooth immediately placed implant, then I'll hand tighten it only. If it's hybrid, like an all-on-4 type restoration, then I will use a torque driver and usually go to 10 to 15 Newton centimeters on the prosthetic screws.
Sure. I mean, I do a lot of work with Nobel, and maybe for their final healed implants, they might say, 15 might be a good rule of thumb for temporaries, and 35 might be a good rule of thumb for final. final abutment settings, and
Right.
and anything like a healing abutment or a cover screw, maybe just finger tighten.
Yeah, I think that's what the recommendation is from Nobel. It's temporaries are 15, and most of the final prosthetic screws are 35, except for their 3.0, and that's 15. So their 3.0 implant, the final torque for a prosthetic screw is 15 Newton centimeters. If you go over that, they found that it can fracture. So you may want to make sure you don't go over that.
Yeah, I'm glad you brought that up. The first time I placed one of those 3.0s, I screwed in the implant, and okay, all was well. And 3 months later, I come back to restore it, or 4 months later, and I go set that thing at 35 Newton centimeters, and that thing just popped, and I thought, oh my gosh, what have I done? Luckily, it broke the top of the screw head, and I was able to back it out and retrieve it and fix it. And then I'd been placing implants for 40 years, but it was a new line. The 3.0 active hadn't been out long, and shame on me, I didn't do my research. And
see that, and that's the interesting thing, because I've heard that a lot. Luckily, that's never happened to me, but sometimes you get in your mode, and oh, Nobel, I know it's 35 Newton centimeters. You kind of memorize these different systems after a while. And but the reason that it broke at the head is because that's the way all of their screws are designed. That's why I trust their recommendations when they say you torque it to this number, you don't go, and that's where you stop. So they designed their screws to break at the head, which was a very smart design, because if it broke into threads, then you'd really be screwed. No pun intended.
Yeah, absolutely. Well, okay, moving away from that, I think we could spend all day on that, and I know we've got a lot of ground to cover here. Let's kind of move into implant issues or implant problems. I know you talk a lot about using the correct implant parts and matching up things, and not cross-contaminating your genetics with implants. I know there's a lot of copycat systems out there. Do you want to take a moment and speak about some of those lab to implant restoration componentry and why that's always good to stay true to one system?
Again, it comes back to the manufacturer. The manufacturers have done the test on their components. Because of that, I stay with the system. So if it's Nobel Biocare, it's a Nobel Biocare abutment. If it's Straumann, it's a Straumann abutment and a Straumann screw. If it's Implant Direct implant, then it's an Implant Direct prosthetic device on top of it. I don't care what you use, but use the same company for the prosthetics, because if you don't, for example, that screw that breaks at the head that was developed by Nobel, if you use a glidewell screw, for example, it's not the same. The design is completely different. It might not break at the head, then it might break at the threads, because they've had to change the screw in order to bypass patent laws, because all of these fitting components have been patented. And if you don't change it, you get sued. So nobody wants to get sued these days, or ever probably, but it's important to follow that. And by changing the components, the other thing that happens is that they change a couple of different things. First, the screws are almost always different. And the things that are different are the heads of the screw. The other things that are different are the pitch of the screw threads are different, because that's been patented. The other thing that's different is, some companies have a carbon abrasive on it, like Nobel. The other companies are just smooth titanium. So nobody's ever tested if these screws are going to work with these abutments inside this type of implant. And it's important to understand that. And it's really important to understand that the labs need to know this, because, the labs many times do a great job, but they don't know what the difference is between a copycat and an original, especially if somebody's coming in and saying, hey, guess what? You can save, 30% on using this. And they need to understand that, because I've had a salesman come into my office and say, how much are you paying for your prosthetic components? And I said, why? And he said, because I could save you 30%. Here, let me show you. And I said, yeah, but those, I like to call them fugazi, by the way. That's my term for fake implants. It comes from the movie Donnie Brasco. I don't know if you've ever seen that movie, but they're fugazi. And he said, no, they're exactly the same. And then I showed him what the original components look like, and he looked at his components and he walked out the door because he knew that he was wrong. But that's how he's been selling them to the labs and to other dentists. He'd go and say they're exactly the same, but you could save 20 to 30%. And when you're buying in bulk, that's a big chunk. So I think it's important to understand that there's a difference. And like I said, if you want to use, you can use any implant system you want as long as you're using the proper components that fit on that system.
Yeah, that's great. I think, it sounds like a Geico commercial, like, hey, if you do this, we'll save you like 15% in 10 minutes. And you're like, oh, great, we can do that. But when you get down to it, it's a little more precise than that, and things shouldn't be tampered with. I've got to be honest, and I'm going to come out and tell a deep, dark secret out of my skeleton of closet here. And I think, 99 dentists out of 100 probably do the same thing. You're right on the lab script, Nobel, 3.5, give me a titanium abutment or, so-and-so abutment and PFM crown or Emax crown and just send it in, right? Well, the lab may give you what you want, but the lab's trying to cut costs too. So the lab may have, done the deal with, this prosthetic piece and not even told you. So you maybe think you're getting a Nobel piece and you're not. You're getting or a Straumann or whatever, and you may be getting a fake part and not even aware of it. So I think it's important to know your labs, know your partners, have that communication and say, okay, if I write Straumann or if I write Implant Direct or I write X, Y, or Z implant, I only want those parts of those corresponding ones, not the knockoffs, because they could be cutting corners and the doctor not even aware of it.
And the other thing that, they can send you stickers, they can send you stickers because if they're using original components, the original components come with stickers. They could put it in the lab slip. The other thing I found, which is something that I never thought about, you just said Emax crown. Well, I have a friend, I looked at their lab work and I said, I don't think this is Emax. So it's like, well, I asked for Emax. Well, it wasn't Emax. It was a different lithium disilicate. I think it was from Brazil or something, which is fine, except, that system has absolutely no research. Emax has a ton of research right now. Because Ivoclar is investing in research. So what the hardness is, what the fracture strength is. And even with your Emax restorations, they can send you a sticker that says Emax to make so that that it's actually Emax. The other thing is, going back to the Fugazi components, if you have a CEREC, you can now make abutments on CEREC, and I think that's great. But you can't buy the components from Sirona, because if you buy the components from Sirona, the little tie base, that means Sirona made them. That means it's not original. So if you want to put a Sirona abutment on a dense ply implant, it's Fugazi. If you want to put a Sirona abutment on a Nobel implant, it's Fugazi. The screw's completely different. The fit of the abutment inside the implant is completely different. People have to be aware of that because I know that's the big push right now. And I know a lot of CEREC users that have absolutely no idea that that's going on until I tell them. And it's something that's, I think, going to unfortunately lead to some complications where screws loosen, where implant screws fracture, abutments fracture. You wear the internal components of the implant, so now you can't thread anything in there. Who knows? There's a lot of different factors that can be involved and a lot of different complications that can occur if you're using Fugazi components. So it's not worth it, in my opinion.
Yeah, I agree. I like using, quality labs that use the real stuff, and, whatever implant you want to do, that's fine. Like we talked about, just, make sure you're staying true to that line because, you get so if you use this implant and this abutment and this screw and this, you're so far off your original at this point, it'd be a miracle if things ever work. So, it's good to stick with that congruent, piece there. So I'll just keep going down the line here of questions I've got. So what's, in your way nowadays, at looking at things, what's the best way to take impressions for single implants? What's the best way to get those impressions and send them into your lab for quality and control and consistency?
I don't know what the best way is. I don't think there's a clear-cut consensus for the best way. I know what I like to do, and I have, a couple of different reasons for that. But Phil, do you have a scanner at your office?
You mean like a Trios or something like that?
Well, something to scan the implant, a scan body for an impression.
No, I don't. I don't right now.
Okay.
And let me tell you why. I think that technology is fantastic. Right now, I just bought a second cone beam, and that's where my money went. And I don't mind the goop, but I do think it's all heading there, and I would like to do that. But still waiting for the price to come down, and I just think, one big toy at a time. So what are your thoughts on that? Because I know a lot of people that love that.
Yeah, no, I think they're great, and I think that's the trend, and that's where we're going. And but yeah, it's a large investment, and in my office, I haven't made that investment yet, and probably like you in the future, I'm looking at them closely, and I think for single implants, they're spot on. And for multiple restorations, for multiple implants, I think there's the studies are showing that there's a little bit more inaccuracy, and that's kind of, something that I'd like to see fixed before I make the investment, because I do a lot of single implants, but I also do a lot of multiple restorations, and it wouldn't be worth it for me right now to have a scanner just for my single units, but maybe sometime in the future, if we see an increase in that, I think that would be beneficial. But one time I was going to give a presentation, and there was a rep from my implant company, and he asked me, or it was a scanner company, or I don't know what it was, but he was trying to sell scanners. So I don't know who he was a rep from, but he asked me, do you have a scanner in your office? And I said, no. I said, so you're still taking, regular impressions? I said, yeah. He said, what kind of phone do you have? And I said, well, I have an iPhone. He's like, well, your iPhone is like a scanner because that's the new technology. You don't use a rotary phone anymore. And I said, you're right. That's a great analogy. But let me ask you a question. How many times have you dropped a phone call on your iPhone? And how many times have you ever dropped a phone call on a rotary phone? Right? So there's still some things that have to be worked out, even though I think the technology is getting there and it's great. In Seattle, we have a lot of windstorms, and I've had to take impressions when the power's out. If you're dependent on the scanner, then the patient's going home. So I think there's a great value in going digital, but I think we still can't forget analog. I think that's important. So what's the best way of taking an impression? I don't know. I don't know what the best way of taking an impression is. I like to use open tray impression coping. That's my preference. I like to use a polyether material. There's great PVSs out there, but polyether in my hands works great. I've used some PVS materials, the light body, and some of those materials allow some movement of the fixture, of the impression coping, and I don't see that with the polyether. So even though the taste is horrible, I prefer polyether.
Yeah, that's a little more old school than I like to do. I can respect that and I like it. But yeah, I do PVS. I do some open tray and closed tray both. But I definitely stay within the boundaries of what I know works for me. And I think that's important. What does your lab like to do? What do they have success with? What works well in your hands, and then have your standards and your basis there. Yeah, I'm still waiting for the scanners to fully arrive. I'm still waiting them to get better, work out more glitches, and get a better price point. And I think it's coming. I think you can definitely use them now, but I can't justify it in my practice either. So that's I'm kind of on the same fence with you on that.
Right.
Okay, so with impressions in mind, I know you've got something to say about abutments too. Gone are the days of, take the impression, stock abutment, stock crown. I don't know that I've ever used a stock abutment ever. And, I've been in implants for, 6 or 7 years now. I don't think that's ever happened once. So talk to me about abutments and why you feel so important about abutments.
Yeah, I think that, abutment design is obviously one of the most important things for the restorative process with implants. And unfortunately, over the phone, it's kind of hard to explain. It's much easier to do with photos and pictures and drawings. But, I did a little experiment one time, and I sent one case to 3 different labs, just local random labs. Well, 1 national, 1 local, 2 local and 1 national. And I just asked them to make me a custom abutment. That's all I wanted. And there was a huge variability in what I got back, just with 3 labs, right? Completely different. One of them looked like a stock abutment, my custom abutment that I paid for looked like a stock abutment. The other one looked like a thimble. The other one had a more anatomical contour. And I asked myself why this happened. And I think it's the education of technicians, because, when we're depending on technicians, we have to depend on what their education was, what their mentality is, and what their background is. And I'm sure that even in some big labs, you get a different technician, you get a slightly different abutment or a completely different abutment. That would be an interesting study to do. But I think it's important to have good communication with your lab. I think it's important to tell them what your objectives are when you're wanting an abutment. I don't like to have an undercut in between my crown and my tissues. I'd like the abutment to support the crown more in an anatomical shape, and I know that's difficult to see because of the soft tissue, but I don't care. I tell the patients, you're going to feel some pressure. And sometimes I tell them, I'm going to numb you because I have to seat this abutment and it's going to push your tissues out of the way. But I prefer that to having, a small abutment and then a hugely over-contoured restoration, because I think hygiene is difficult. I think cementation cleanup is difficult. And I think ultimately having that small abutment makes the whole system weaker. So I'd like a big, bulkier abutment. And the other thing to keep in mind is that, when we go back and talk about, because like you said, the way I was taught in school was using stock abutments, and I don't know if that's happening in schools anymore. And it's not happening at the University of Washington. They're using just custom abutments. And I can't speak for universities all over the world or the country. But one thing that I think it's really important for restorative dentists to understand and for schools to teach is actually some very important things when it comes to implant restorations. And that's screw mechanics, right? I mean, I never was taught this in school. I did my dental school. I did 2 years of AGD. I did 3 years of pros. We had a little bit of a lit review on this, but there's no real course or class that teaches you this. Screw mechanics are huge. And this is something that, a lot of people come to me and they say, I want to start getting into placing implants. And I said, that's great. And I said, do you feel comfortable restoring implants? And they say, yes. And then I asked them, okay, explain what preload is. Explain about screw elongation. Explain to me about screw deformation. These are things that we need to know as restorative dentists. And then I think once you understand your restorative process fully, that's the time to go and take it a step further. But I see a lot of times, a lot of people going now to start placing implants. And I think that's great. I think if you get the proper training, then you're going to be in really good hands and you're going to be in really good shape and you're going to be able to give your patients good treatment. But, a weekend course that teaches you how to put an implant in a fake mandible, I think that's scary to then take the next step and start placing implants. And I see that a lot, unfortunately. So I don't know if you have any comments on that. I know you've done a lot of training, so it's something that I think might change the way we do implants, because if we're having more and more untrained dentists placing implants, I think that implants are going to get a bad name, and they're going to get a bad name, and it's going to affect us, the dentists. It's going to affect the labs. It's going to affect the implant companies, and ultimately it's going to affect the patient.
Yeah. Well, I'll go back just a second on that with the abutments. I couldn't agree more. I like big fat abutments. I like them to look like crown preps. I mean, if I prep number 30, I want my abutment for number 30 to look like a prepped crown. And like I said, I numb them up, and if that abutment doesn't blanch the tissue and hurt when I screw it in, then I feel like my lab tech failed me. So on that, do you like to cover your cover screws with
Teflon?
Teflon, yeah. You like to just cram it with Teflon, and then do you plug composite over the top, or just pack it with that and then cement?
It depends. It depends what technique I'm using. But yeah, I like to use Teflon. And I like to we sterilize our Teflon tape. We put it in autoclavable bags, or my assistant cuts it into strips. We open the bag completely, lay the strips in, because you can't slide the strips in. Teflon is like saran wrap. Right? If it sticks to itself, then you're trying to pull it apart. So you rip the bag completely open, lay the pieces of Teflon tape in, close the bag, and then with some autoclavable tape, you seal the sides, and then you run it through, and then what they'll do is they'll cut the top of the bag, and then they'll take some hemostats and pull out one strand at a time. But yeah, I like to use Teflon tape, and it's because it's a very convenient material to remove, and it's less prone to bacterial contamination. There's a study on that in quintessence, and compared to cotton. I used to use cotton pellets, but cotton is an organic material, and bacteria prefer organic material. Teflon tape is inorganic, so it will attract much less bacteria. So yeah, I really like the Teflon tape.
Great, yeah, and I think the more and more implants are placed and screwed and fixed and all that. I mean, they're becoming more and more used, and so it's even if you're not placing them, you can do a lot of damage just restoring them. Like you said, you can be using bad abutments, you can be screwing things in wrong. Probably the most damage you can do is cementing things wrong. So why don't so we talked about screwing, abutments, impressions. Why don't you take a minute and talk about cement? And I know you could spend an hour on that, but break this down for me in 5 to 10 minutes. Pretend I don't know anything about cementing an implant. Just pretend I'm a 2 or 3 year old postgraduate, and I've cemented 1,000 crowns by now, and I thought, well, I want to go cement my first couple implant crowns. How do I treat that different? Let's just say we have the proper abutment, because when thinking about cementation, it does start with abutment design. But let's just say that that's correct. I sent it to a lab, and they thought ahead of me and made a good abutment. I didn't know what I was doing, and they sent me back a great abutment. And let's just say it's a cementable crown, just because most still are in this country. Kind of walk me through how the different number of ways I could blow this as general DDS, and how you would kind of propose to do things differently than what most people are doing.
Yeah, I think that you said most of them are like that in this country, but that's true in the world, in the whole world. We as a profession are doing, I don't know what the exact number is, but probably 80% cement retained. That's just a guesstimation, but yeah, so it's the most popular technique to restore implants by far. What do we look at when we're going to cement a crown? Well, the first thing we want to look at is cement type, right? So there's some characteristics of different cements, and the characteristics of the cements that I would like are that these cements would be radiopaque. Now, two of the best-selling implant-specific cements these are cements that were made specifically for implants, are completely radiolucent. You cannot see them on an X-ray. Now, when we're concerned, and everybody knows this now, I've been lecturing on this about 8 years now. Everybody knows about that cement is detrimental to the health of the peri-implant soft tissue and the hard tissue. We're looking at companies to give us good products, but they're making these cements radiolucent. Does that make any sense? If we're concerned about excess, we want to take an X-ray and make sure that everything's cleaned out. So that's one characteristic. The second characteristic is what causes peri-implant disease. There's a couple of theories, but most likely it's bacteria. Now, if you look at some cements, you'd like the characteristics of the cements, you'd like them to be antibacterial. And there's a couple studies now in the literature that look at show that how some cements are very bacteriostatic, and some promote the growth of bacteria. Those happen to be some of the implant-specific cements that promote bacteria, unfortunately. And the other thing that you want to look at is solubility. If you have a cement that can be somewhat soluble in water, in circular fluid, that probably would be an advantage to something that's not soluble when left in excess. So these are just some characteristics that we looked at. And I've done a couple of studies on these topics, but the other thing you want to look at is, again, the abutment design. So do you want to have your margins at 1 millimeter subgingival, 2 millimeter subgingival, equigingival? Where is your ideal abutment margin placement? And the most common abutment margin placement is 1 millimeter subgingival. The reason that that's the most common placement is because that's the default setting to a lot of CAD/CAM abutments. And most of the abutments today are probably CAD/CAM, right? A lot of labs have invested. We still have a lot of UCLA, but the price of gold is changing that. So the default setting to many CAD/CAM milling machines is to place the abutment margin a millimeter subgingival. Now, we know from a couple of studies by Linkevicius that might be too deep. And so you have to be specific on when you're speaking to your labs. I mean, if you have the ability to keep the lingual margin supragingival, do it. If you have the ability to keep the interproximal margin supragingival, do it. Even the buccal margin, if you can go supragingival, do it. That's how I've been cementing my crowns for the past 7 years. I've been keeping everything above the gun, supragingival. And there's a couple of techniques that I talk about to do that, but it's been by far my one of my favorite techniques. And the other thing is cement elimination techniques. I published a paper with my buddy Chandra Lagwani, and we looked at what technique, or one technique that we liked of eliminating excess cement. And it's by making a copy abutment. So we made a copy abutment that's 50 microns smaller than the original abutment. The way you do that is you take your crown, you line it with one layer of Teflon tape, you inject a fast-setting PVS material, and then you pull it out, and you have a copy abutment that's 50 microns smaller than the original abutment, because the Teflon tape is the white Teflon tape. There's different colors of Teflon tape, which indicate different thicknesses. You can buy them at Home Depot. So the white Teflon tape has a thickness of 50 microns, and that's usually the thickness of a die spacer. So that technique has now been looked at in 4 different studies in the literature, and it's been found to have the best way to reduce excess cement. And I actually did a little experiment. I did a hands-on course in Denver in September, and there was about 20 participants. And what we did was we had abutments and crowns and copy abutments, and I had everyone place cement in the crown, use their copy abutment to push out the excess, because that's what it's used for, and then take the crown off the copy abutment and put it on the original abutment. And then after a few seconds, pull it off before the cement was completely set. And what we found was that there was I don't know if there was a direct contact between the intaglia of the crown and the abutment, but there was cement covering the entire intaglia of the crown. And if it broke off, it was corresponding to where it broke off on the abutment. Does that make sense?
Sure.
So the scariest part about this technique is that many times you use this technique and you don't see any excess cement. And that's really hard to get over. I know that because it was hard for me to get over. You say, oh, I didn't put enough cement here, this one's going to come off. But, after seeing those 20, samples we did in Denver, I can be sure that this is a technique that works well. And the 4 other studies talk about that as well.
I heard you talk about that 2 years ago, and I started using that technique in my practice when cementing. And I have had 20 of those since then that I didn't see anything come out. And I thought, oh, crap, do I even have enough in there? And I know better. But that's just the old, hey, a little's good, a lot's better. Teaching dental school, load that sucker up and smash it down on the tooth. And that may work, with supragingival margins on a posterior PFM with, eugenol cement. But with, implants, you don't need that much. And I've never had one come off. On those 20 or 30 that I've never seen it come out, and I thought, did I even use enough? I've never had one come off. And so it comes with proper abutment design. It comes with proper retention, where you put your margins. And then that's a great way to get rid of the excess before, because otherwise, if you jam it up, if you load it up and jam it in, you're pushing all that cement right down to the base of the implant connection, and that's just going to doom it for sure.
Yeah, I it's a technique that I think is very helpful and very useful, it's another way. There's a lot of techniques, and when I give a lecture, for an oral surgery group a few months back, and the oral surgeon says, "Why are you even talking about cement? Just tell everyone to screw retain it." And I said, "That it doesn't work that way. I'm not going to go into an audience and change everybody's mind because they already have their preferences. But if we can give them different techniques to help prevent this from happening, then I've done my job. If I just give you one way of doing it, maybe one or two people will do it. But if I give you 5 or 7 different ways of doing it, then everybody will take one thing back and do it or try it. And, if they don't like that one, they have the ability to try something else. So, my goal is to do that, is just to teach different ways to prevent complications because, everybody wants to learn from their mistakes, but I think it's a lot easier to learn from somebody else's mistake, because that way you didn't have to suffer the consequences of making a mistake. You can learn from somebody else's mistake. It's a lot easier.
So I'm going to put you on the spot here. I know I've kept you on the phone as long as I told you I would, and then we'll wrap up. I'm just going to go real quick, bang, bang, bang. And these may not be one-answer questions, but what is the best cement to use on cementing a crown?
That's a good one. That's not a one-word answer.
All right,
sure.
I know it wasn't, but can you break that down into simple terms? If you had to say, hey, in the front I use this, in the back I use that, or just how about what are you using in your practice?
Well, I'll tell you this. The characteristics that I told you about cements, something that's radiopaque, something that's antibacterial, and something that's soluble. There's only a certain category of cements that have those 3 characteristics. They happen to be zinc-containing cements. Zinc is antibacterial, it's radiopaque, and zinc cements have been found to be soluble in liquids. Resin cements or resin-containing cements are not. And the other thing that resin cements have, and I remember I said that in most cases, peri-implant disease is caused by bacteria, but there could be some other factors involved. For example, an allergic response. Resin cements are methacrylate cements, and there's a huge number of our patient population that have a predisposed sensitivity to methacrylates. In fact, the Contact Dermatitis Society of America voted methacrylates the contact allergen of the year in 2012. So it could be an allergic response that's causing a lot of these complications, and every resin cement is a methacrylate. So if you're pushing these cements down into patients' tissues, you could be causing an allergic reaction. If you read the MSDS sheets of these resin cements, you'll find that it says, please use gloves when handling. Do not contact directly with skin. But we're pushing it into our patients' tissues. So the cements I would use would be a zinc-containing cement. They're radiopaque, they're soluble, and they're antibacterial. Zinc phosphate, Tempon. If you're worried about retention, use zinc phosphate. It has higher retention values. But Tempon's a great cement, and I use Tempon in many cases. Sometimes I use zinc phosphate. Sometimes I use, this is sort of counterintuitive, but and you asked me what I do in my practice, so I'm going to tell you. But I use resin cements. But I only use resin cements on those cases that have super gingival margin, because I have a porcelain abutment margin and I have a porcelain crown margin. And I'm bonding the porcelain to the porcelain with a resin cement. But I use a rubber dam and I protect the tissues. And I can do that because I have a super gingival margin.
Well, I think that's a great answer. So you've got 3 choices for 3 different scenarios of the mouth, and there's no right one, but you've got at least more than one trick in your bag there. So I know you're a big proponent of screw retained. I think a lot of people are. One of the issues I run into with screw retainment is, okay, I put the Teflon tape down. Then what? What should I cover with that hole? What kind of composite or filler material? Give me a trick to use with covering these screw accesses, because I think a lot of times people don't necessarily like the way those look or hold up over time either. So
Well, composite is a great material. It's readily available. It's inexpensive. The disadvantages are it's not aesthetic, and the wear characteristics are higher than the adjacent porcelain. So if you have a contact in the composite, ideally we were taught to load implants down the long axis, but that's where your screw axis hole is. So if you have composite there, it's going to wear. My lab makes porcelain plugs. So we use the same porcelain as the crown. It's a little plug that fits in. It looks like a number 8, and it just fits over the screw head. And there's a little anti-rotational feature that's why it looks like a number 8. But the top of the 8 is smaller than the bottom of the 8, and the bottom of the 8 is where the screw axis hole is. So I've been using that technique. We published that technique in the Journal of Aesthetic and Restorative Dentistry. I think it's 2011. It's just one technique that we've been using in order to get the best result. And that's just bonded like an inlay. It fits into the porcelain like an inlay.
That's great. I love that. I think that's fantastic. That's going the extra mile. But you know what? Sometimes you got to do what's best. And so I think that's great. Have you ever done that coming out the facial of one of these anteriors and actually have it look good, or is that never a good idea?
Well, I've done that a few times. Sometimes they look pretty good, but it's a little bit more unpredictable. But sometimes I've done it just to prove a point because one of the surgeons said, there's no bone, and I'm not going to be able to place this implant where you want it, so you're not going to be able to spear retain this one. And I said, I bet you I will. So I proved them wrong, and that one fortunately looked good, so I sent him the picture of it.
You don't have to show them the ones that don't. So
yeah.
We'll shut this thing down here. I know I've kept you at about your limit there. Give me any 3 of your best tips or something big we haven't covered yet. Is there a secret out we haven't talked about? Is there a couple secrets you want to share with people that we haven't covered, and then tell people if they're interested in catching you on the lecture circuit or getting a hold of you, how they can do that?
Sure. Let's see. So what can I say? I think that my practice secret is that I used to come out, when I came out of school, I thought, I knew it all, right? And it's like, okay, we're going to do this. And I would tell patients, we're going to make this for you. It's going to last the rest of your life. And I was very humbled to find a lot of what I do doesn't last. A lot of what any of us do doesn't last, right? I mean, you've had those crowns that porcelain fractured or whatever, right? So I don't say that anymore. And I think that's something that we do as a profession as well. I think we say things like your final crown and your final restoration. That gives the patient the idea that it's going to last forever. And when it doesn't, they're disappointed. So I think we need to have really honest conversations with our patients and tell them, we're going to do this to the best of our ability, and we're working with, your body, your biology, your physiology, componentry, and there's a lot of factors that are involved here that will determine the longevity of our work. And sometimes it lasts longer than others, but this might not be the last time that you have to do this. And, I like to say that to patients now because it gives me the ability to communicate our limitations, which I think is important. And they understand it when, they come back and something happens and we can fix it or we can't fix it. But they understand that now. If I say, you're going to love this, you're going to have this the rest of your life, unless they're 99 years old, I typically don't say that. And I think that's important to communicate with our patients because I don't know about you, but and I don't know what happens in Kansas City, but a lot of people don't like dentists. I don't know if you've noticed that. I get that comment a lot. I hate the dentist. Have you ever heard that comment?
Almost every day. I've heard it 3 times today, actually. So yeah, it's exactly. Definitely out here too.
Yeah. So I like to try to do whatever we can as a profession to kind of get patients back in our corner, get the public back in our corner. We want our profession to be well respected. And I think it's important because if that happens, it benefits us all. So I don't know what else I can tell you.
Yeah, no, that's good. I think, setting expectations is important. And, like you said, people ask me a lot, how long is this going to last? And I say, nothing lasts forever. And this dentistry probably won't too. But I'm going to do everything I can and do a good job. And he's a high quality lab. You got to do everything you can, and you got to take care of it and brush your teeth and come in and see me. And implants, we say they're great because they're a lifetime solution. I mean, nothing's a lifetime solution. I mean, this we're hoping to give you a great solution that hopefully can last as long as you need it to. But yeah, crowns will be remade, and that's why the screw access is a great way, because retrievability and functionality of that is so much easier than fishing for the opening. And so setting expectations, whether that's with patients, money, or whether that's how many appointments that's going to be. This is why your teeth aren't going to be in one day, or why that's hey, how long is this going to last, or what happens if there's issues. So I think having those conversations ahead of time and setting the expectations from the moment they hit the door till to the final restoration is complete, I think is definitely a good idea.
Yeah, that's like I said, I didn't do that as right away, but I've learned over the years it's the better way to do it.
It is, and experience is the mother of all teacher, and we've all been burned a time or two, and so you don't do things the way you did 10 years ago, and hopefully 10 years from now we're not doing things the way we did back then. So it's an ever-changing process. So, well, Alfonso, I really appreciate your time. I know you're lecturing tonight on this material again, so you get to talk about this all over again, and so if anybody has questions for you or was curious about your lecturing, do you have a website or any way for people to get a hold of you that wants to either bring you to their club to speak or catch you out on the circuit somewhere, or just hey, I've got a question about X, Y, and Z. What
Sure.
Can you give people?
I am a Seattle Study Club speaker, so I'm in the book. So if they have a Seattle Study Club, if not, I'm not really. I should be a bigger self promoter. I'm horrible at that. I should have a website for my speaking, but I don't. But you can email me. It's just Dr. and then my last name, P as in Paul, Ineyro @hotmail.com. Very, very simple. And, and even with questions, if there's any questions about some of the comments that I made, I'm really good at getting back on email. And that's the best way to get a hold of me. Thanks so much.
I always take down everybody's emails, and I always think I'm going to have a million questions, but it's sometimes you just got to get out there and do it. And, but it's good to have resources and mentors out there that are willing to share. And I know, from having hear you speak, I was just amazed at the amount of knowledge I learned in that couple hours. So I really respect what you're doing for the dental implant side of the practice, and think you're doing a great job. So appreciate all the research you do and the teaching and your willingness to share.
Yeah, well, thank you for having me. And my main goal is to help everyone avoid complications. I mean, really, that's why this whole thing started. And, here and there, people are starting to get wind of it and doing things slightly differently. That's all it takes. Even knowing that the problem exists is sometimes all you need. So, it's been a fun ride, and I love what I do, and I know that you feel the same way. So it was great chatting with you.
All right. Well, you go knock them dead, and I'll catch you at some point or another down the road here from now. And if we get a chance, maybe we'll have you back on the show.
Sure. Looking forward to it.
All right. Thank you so much.
Thank you.